Well, welcome again, everyone. For those of you who just joined us, I'm Priscilla, and I'm the Customer Success Manager here at Smyrna. And we are really excited to be joined today by leadership from Tennessee Oncology, and they are going to be discussing their experience working with Smyrna. So first, I wanted to take a moment to go through our agenda. Here's what we have planned for today. We're going to go through a few quick housekeeping items, followed by some introductions from the Tennessee Oncology team. We'll then have an interactive discussion about their experience working with Smyrna, and we will leave some time at the end for audience question and answers. You will see a little Q&A box in the bottom of your screen. Please contribute any questions you have in there as we go through the webinar, and we will just wait to address them until the end. So for our housekeeping items, this session is being recorded and you will receive a link to the recording after the webinar in your inbox. Secondly, you will receive a short post-webinar survey. Your feedback helps us streamline our focus based on your interests, so we do really appreciate you taking a quick moment to answer those questions. And then lastly, just to address it again, we do have that Q&A box. Please contribute your questions while we're going through the discussion, and then we will take some time at the end of the webinar to go through all of those. So first, I wanted to discuss a little bit about Tennessee Oncology and give a quick overview of their business. So they care for over 85% of patients in Nashville and nearly 50% statewide. Their network includes 79 clinical sites, over 150 physicians, and over 600 treatment chairs. They employ more than 250 infusion nurses, and they were the founding members of OneOncology. They are now the third largest community practice in the United States. And I wanted to take a moment for everyone in Tennessee Oncology team who has joined us today to introduce themselves. Please share your role, your responsibilities, and a little bit about your background. Susan, would you like to start us off?
Sure. Good afternoon, everyone. I'm Susan Fraley. I'm the Chief Operations Officer at Tennessee Oncology. In my role, I have the opportunity to work with the different divisions, leadership, and team members across the organization for medical oncology, radiation oncology, imaging, surgery, development teams, project management teams, our laboratory, and our pharmacy services. In December, I will celebrate 20 years with Tennessee Oncology, and in my 20 years here, I have had the opportunity to work in many different areas, but mostly focused on operations and project management.
Thank you, Susan. Larry, would you like to introduce yourself?
Sure. Hey, everybody. Thanks for having me. My name is Larry Bilbrey. I am the Senior Director of Digital Innovation, Data and Digital Innovation for Tennessee Oncology, and the Senior Director of Digital Innovation for OneOncology. I have a dual role. On the Tennessee Oncology side, data, worked with Smyrna for a long time to get them the data and stuff they need for their product, but I do all of the data things for Tennessee Oncology, work on the AI side, and then also do the AI side with OneOncology, trying to help determine what our roadmap is going to be. I've worked with Susan for a long time. She's gotten me by almost a year, but I'll be 20 years next year. She and I have worked together in a lot of operations area. That's where I started, was in operations as well. Moved over to data and digital innovation back in 2020. So good to see everybody.
Thank you, Larry. Kathleen, would you like to introduce yourself?
Sure. Hi, everybody. I'm Kathleen Murphy. I'm the Executive Director of Nursing Services for Tennessee Oncology. My scope of responsibilities are global oversight of nursing services across the enterprise, as well as supply chain management for Tennessee Oncology and occupational health, safety, and emergency preparedness for the organization. I am a registered nurse by training and experience. I've been a nurse for 43 years. My last 10 years have been with Tennessee Oncology. Prior to that, I've worked at academic medical centers, for-profit, private, large healthcare organizations, and then Tennessee Oncology. So looking forward to speaking with all of you.
Thank you all so much, and we are very much looking forward to learning from your insights. So over the next 30 to 35 minutes, we want to explore your experience with SMRTA from your initial challenges and then also the results that you've achieved. Given the scale of your organization, we're also excited to discuss some of the big picture takeaways. So I did want to take just a moment to discuss SMRTA and about what we are about. So before we jump into the interactive discussion, I wanted to take a minute to introduce SMRTA. For those of you who are not familiar with us, we are an AI-based platform that can help optimize cancer center resources and improve capacity management. We help you achieve this by making it easy to maintain balanced patient to nurse ratios throughout the day, increasing patient capacity with existing staff, analyzing and understanding bottlenecks and capacity constraints, and then also unifying and tracking key performance indicators that can help you understand and improve the operational efficiency of your business. Cool. So moving back to our discussion, I did want to first talk about what operations look like before working with SMRTA. So Susan, can you share any insights with our audience about some of the key resource and capacity management challenges that Tennessee Oncology faced before partnering with SMRTA? And how are those challenges affecting your operations?
Yeah, sure. Thank you, Priscilla. Yes, I think the best way I could probably describe operations before partnering with SMRTA is it was a little bit of the wild, wild west. We have multiple sites of service. As we saw, we have about 35 medical oncology clinics currently. And really at the time, before we joined partnership with SMRTA, everyone was just working kind of within their own guidelines, not really relying on any kind of data or analytics or any kind of standardization. It was just, how do we manage this clinic with what we have, with the resources, the space, and what we've been given. So we had a lot of challenges with what I would call the infamous bell curve of everyone coming into the infusion center between the hours of 10 and 2. And that was because it was driven a lot by the provider schedule, and it was also driven by patient availability. So we had a lot of challenges just making sure we could even out our resources, that we had the staffing in place that could help through those busy times, and then also in the downtime. It made it really challenging for our teams to be able to get lunches, to even organize the treatment room by their nursing team. From a scheduling perspective, it was really the scheduling team trying to put together what I would consider like a jigsaw puzzle. They were looking at different pieces and parts of the patient's appointment. They were trying to manipulate kind of the schedule by looking at multiple different resources, trying to piece parts together just to make things work right. And so they were just really doing the best that they could, but it was definitely a daily challenge. And without any tool or guidance to help inform our decisions, that each of the clinics were just really trying to make it from a perspective of putting all the different pieces into place, and sometimes having to move those pieces around very quickly as the day changed. So lots of challenges that were presented to them.
Sounds incredibly challenging. What ultimately prompted your team to seek a solution like SMRTA, and what were some of the biggest scheduling or nurse assignment inefficiencies that you hope to solve?
Yeah. So, I think as, technology was introduced into the practice, and I've been here long enough to remember when we had paper charts and the challenge of integrating all of those paper charts into an electronic health system. The EHRs are really great for lots of different things, but one of the opportunities that we've seen over the years is partnerships of different technologies to help kind of elevate or enhance different pieces and parts. And scheduling from a patient scheduling perspective and also from a staff-based scheduling model was an opportunity that we had seen over the years. And our previous CEO, Dr. Jeff Patton, who is now the CEO of OneOncology, was introduced to the SMRTA team and quickly said, hey, this is something that we really need to look into. And that really started our conversations with the SMRTA team and the opportunities that we had with this technology. So things kind of just fell into place from there, right? Our challenges were challenges that so many others were having in community oncology, and something that the SMRTA team had experience in, and that's what led to the partnership and the development. Once again, kind of at that time, we were seeing different challenges among the clinics, and all of our clinics are different sizes. different physical space, different volumes, depending on the number of providers that were there. So we knew that the solution had to be something that we could create standardization, but yet also offer a layer of customization to accommodate for all those different challenges that present in each one of our locations. So for example, with the nursing assignments, I remember speaking to one of the clinic managers, and before we introduced the technology, they would spend hours of kind of, writing schedules down on paper, looking at the schedule in the system, trying to figure out the nurses that they had, how they could balance out the acuities. This process would take them hours, a few days before the clinic, to only for it to change the day of clinic because there was call outs or there was add-ons or things like that. So that was a major challenge and a lot of time that our managers was spending. And then on the scheduling side, again, I can't overemphasize the complexity that was being presented to the schedulers, them having to try to solve a lot of times these puzzle pieces that involved layers and elements of clinical knowledge that, our schedulers are non-clinical, right, by training. And so trying to get them to and give them the tools and the information to help them be successful was really something we were faced as a challenge. Yes, they had counterparts and individuals in the clinic from a clinical side, but just, when you're in front of a patient and you're trying to piece the parts together, it was really difficult, and then led to that unbalance of the schedule where we had those peak hours from 10 to 2 and, not really utilizing our resources efficiently.
Thank you for that, Susan. That was really insightful. Larry or Kathleen, do you have anything that you'd like to add to Susan's remarks about operations before?
Yeah, I think the only thing I would add is that, as Susan mentioned, it was taking the managers a very long time in order to be able to do assignments, but many of our clinics didn't even do assignments. They used very much a team approach, and whatever patient walked in the door, whoever was available took care of that patient, which led to unbalanced workloads. Also, it was very, very difficult for us to measure our chair capacities and how we were using chair capacities in order to determine even what staffing we needed or what skill mix we needed. Did we need all RNs? Could we use LPNs or even medical assistants to help provide some of the care?
Thank you for that. Now that we've covered the big picture, let's talk a little bit about implementation. Larry, from a technical perspective, can you share any insights with our audience on how OncoSmart was rolled out across Tennessee Oncology, and what did that process look like? What advice would you share with other organizations?
Yeah, Susan touched on a lot of it, but getting very specific. So we had one clinic that was very difficult to manage the scheduling, and it was difficult for the life of the clinic. Like, it wasn't new or anything like that. And so that was really sort of the genesis of this, is like, could we figure out a way to go to our most difficult clinic and come up with a way to balance the schedule? So we started there, and based on starting with, like, it was one of our larger clinics as well, starting with a large, difficult clinic, we sort of just adopted that as our, and I think we do with a lot of things. Let's get the hard stuff figured out first. And so that's what we did, right? We rolled out to that clinic, and then we rolled out to our largest clinic after that, and then the next largest clinic. And we did our large hard clinics first, and then sort of worked our way down to the maybe a little bit easier to manage clinics, or at least easier to roll out a solution. And so that's how we sort of approached implementation. I worked with the Smyrna team on the technical side from a data standpoint using OncoEMR. And I think maybe a lot of the people on here have OncoEMR, but this works for any EMR. There's not a lot of data feeds that are real time. And so I worked with the Smyrna team to come up with data feeds on our own that we're able to get to them on a daily basis so they can update, and then using other things like SIU feeds and stuff like that to give them as much real-time information as possible. So that was a big piece of getting everything set up, is, start with the tough clinics, figuring out the problem, get all the data pieces, basically build the blueprint of what's like worst case scenario. And then, from there, it was easy. And I think, just correct me if I'm wrong here, Susan, but I think as of 2 weeks ago, every one of our sites is now on Smyrna fully, correct?
Yes,
Yep. Yep.
that's correct.
Wonderful.
And then
Kathleen from,
sorry, I know the second part of your
go ahead.
question. What's the advice that I could give people on the implementation side? Work with the Smyrna guys, work with Streeter and the technical team on the Smyrna side. They've done this many, many, many times before. They've got it pretty much down to science. We can give them a clinic, and within like 2 or 3 weeks, it's ready to go from a technical standpoint, right? So they've done it so many times. So really lean on them. They have the expertise at this point to answer a lot of your questions, and then any operational questions, we're always available too.
Thank you, Larry. Kathleen, from an operational standpoint, how did you approach the rollout and training?
Yes, so we did a phased approach. As Larry mentioned, we identified a few clinics to start with, which we classified as our areas of greatest opportunity. If we could make it work there, we could make it work other places. But we also phased the different arms of the Smarta product, which means we worked really, really hard on the optimizing scheduling piece of it. First, as our first priority, working with our patient services staff, getting them trained on how to use the optimizer. And while we were working on that piece, we were simultaneously working on the iAssign piece, gathering the data, gathering all the information we needed in order to bring iAssign in as part two of the Smarta product, which worked really, really well for us using that two phases approach. And at the same time, we were also working with our leadership team on the data and analytics and how they were able to go in and use the system and educating them on reports that they could run to see what our compliance and our adherence rates were for the optimizer, and then looking at the iAssigns and how was that balancing nursing, number of patients they were taking care of, we use an acuity system, working within our acuity points, and then just continue to refine as we continue to roll out.
Thank you, Kathleen. Larry, or rather, integration can often be pretty tricky. How was the deployment of OncoSmart with your EHR handled, and how smooth was that process? Also, how critical was single sign-on to your user experience?
Yeah, single sign-on is huge. Basic team at Smyrna and then your IT team can help put that on the machines that need it. Once the staff member signs in for the first time, they don't have to sign in again, right? It's a one and done kind of thing. And so that's been huge because we all know how much we hate logging into multiple systems all the time, every day. So I can't stress how great that's been to have the single sign on. The integration piece has been good. Flatiron very receptive. I saw a question in the in the questions. I don't know if it'd be good to sort of talk about that as well, because she asked specifically about the EMR stuff. But I think that the big thing about the integration with OncoEMR and the gap with a lot of other technical resources is that it's easy to see when an appointment is available, but if you don't have the context of when appointments should be available, then it makes these kind of solutions really, really difficult, right? So the integration with OncoEMR has worked extremely well in that it's a pop-up over the scheduling page that the schedulers can see, and there's two pieces going on, and I don't want to go too far into it because I don't know as much as the Smyrna guys know. But one side is the template that they built, using AI, using your data, figuring out what your patterns are and all that. And then there's like the second piece is this dynamic look at what is actually happening on the scheduling page for that day that's picked. And so it can actually see when there are gaps on the schedule, and then it can run it against, the algorithm and that template to say, 10 o'clock's available for this doctor. Should I put a patient patient there, and if I shouldn't, when should I put that patient? And I think that's what's really critical about the integration with the scheduling piece. The iAssign integration, it doesn't really integrate with the EMR from an overlay standpoint, but it does have that data from the EMR coming in on the back end. So it'll have your patients for that day should be updated up to the minute. I think it refreshes pretty quickly. You can force a refresh as well. So if you add a patient on now, in just a couple minutes, it'll reflect an iAssign, and that's all on the back end. So there's nothing sort of EMR or nothing that relies on the EMR for that to run. So the integration has been great. The problem solving that they've been able to do has been wonderful. So
Thank you, Larry. Susan, did you have anything that you wanted to add in regard to implementation before we move on to our results questions?
Yeah, I would just like to add that, no one likes change. So when you're adding in a new technology and you're changing, kind of what they've known, quote unquote, for a while, it's always difficult. So my advice, outside of everything, what Larry and Kathleen said are very important. The other thing I would just recommend is to be transparent to your teams about the goals of the project, what you're trying to accomplish. Encourage your management teams to utilize the tools that are given within the system, from the data analytics and even, predicting things in the future, right? So you can say, what if we added a physician? What would it look like? How would it inform us in staffing? And so really make sure you're discussing that with your teams and you're sharing the importance of that. At the staff level, I think it's also important to help them understand the benefits of the tool and what they're going to be able to gain in each of their respective roles, whether it's scheduling, nursing, whichever area that you're speaking with. The other thing I highly recommend is a physician champion. So having a physician involved in the project is really important, because once again, the tool is as good as what we provided in the scheduling template. So setting up the templates and working with your physicians to make sure that the tool complements their schedule. We don't want the physician schedules driving everything. You do want to take that into consideration, but you want it to complement, right? So I think having a physician champion so that you can speak not only to the staff and really the team members that are directly affected, but also the physicians, the APPs, any of your providers in your group is really important. We had a wonderful physician champion for us, and it was very helpful in just rolling out the product and the success at each location as we were talking to the teams and introducing it. So I think that would be my advice from that perspective.
Thank you, Susan. So transitioning forward to kind of focus on the results, over the last few years, Tennessee Oncology has had measurable benefits from using OncoSmart. We'd love to hear what's made the biggest impact. So Larry, what were your original success criteria when you began this partnership, and what metrics have you found most valuable to gather and track over?
yeah, so I understand my internet's a little glitchy, so I apologize, guys. So the original metrics we looked at were the patients in chair metrics. So it's basically being able to how many chairs you have, and like a real-time graph. And I think you may have had an example on an earlier slide of the capacity, the number of patients that are in that chair throughout certain hours of the day. You can even look at it by the day of the week and everything like that. That's really important. When we originally set this up, we used 75%. I'm going to turn my video off just a second because I think my audio might be more important. Just see if that helps my connection here. So having the 75% capacity was important because we want to be able to allow for add-ons, because in oncology, I think we all know that we have patients who walk in are sick, or they see the physician says they need to get fluids or whatever. So we have this 75% capacity. We sort of monitored that at every clinic for each day of the week, where their capacity was in the treatment room, and we use that to help make decisions. Susan talked about it just a second ago, but looking at sort of future planning, there are additional chairs that we need to add to the clinic because they're getting really busy. Do we look at space allocation, whatever? So that was an original one that we would look at. We use it for staffing as well. The other one we look at is the compliance, the scheduling compliance, basically with the recommendations that are given to the staff, we're able to look and see if it's an exact match, meaning that all of the different criteria of the appointment were found and able to be scheduled. An approximate match, which means most of it was, but maybe there's one or two pieces that we weren't able to find a good match for. And then there's what we call manuals, which is where a recommendation wasn't followed and another time was picked, and there may have been reasons for that. But just making sure that the team is using the recommendations, we would watch that compliance. And if there was any, sort of outliers, and, we would address that and just see if we could figure out why that we had manual. Sometimes it's a valid reason. Sometimes it's more, uh, just anecdotal. The patient wanted to come in at that time, and Susan may have more to say about that. But yeah, those were the big ones that we looked at. And then when we got I assign going, we really paid attention to the nurse ratios, the acuity numbers per nurse, per clinic, as well as the number of patients per nurse, and just trying to look at those balances across all the different clinics. Those are the big metrics that we started with.
Thank you, Larry. Susan, can you share any insights with our audience on how the patient scheduling process has evolved since adopting OncoSmart?
Yeah, I think, it's multi-layered. Larry and Kathleen have touched on a few things. I think, back to the original kind of problem that we were trying to solve, where the schedule is really just kind of open, we had a lot of internal kind of re-education and coaching that we had to do. We, of course, our patients come first in everything that we do, but we also want to make sure they have the best experience. So I think that this tool has allowed us to be able to do that. The schedulers, are kind of, trained that we should offer the times that the tool presents as the best matches. So instead of saying, Miss Smith, what time would you like to come in next Thursday? We've asked them to say, Mrs. Smith, we have 9:30 and 10. Which one of those work best for you? And I think that that's really helped overall with the scheduling experience for the patient and just the overall experience while in the clinic. And then I also think from just a, kind of a broader scheduling perspective, it also had us take a deeper look at other things that tie into the scheduling. So for example, our physician templates. And we worked with Larry and his team on really diving into the physician templates. What are their volumes? How many time slots do they have available for new patients versus returns? And that really is critical because that's what drives their template, which is what drives the schedule and the options for the patient's appointment. So overall, I think it just has helped us take a deeper dive into all the different pieces and parts that basically tie into the schedule. And then that gives our scheduling team all the right tools to be able to feel confident in the appointment times that are being presented. And also from a patient experience side, we don't want them to wait. We want them to come in when the availability is good and they can come in and get what they need and then carry on with the rest of their day. So lots of benefits, but it is multi-layered. And I think that's really important to know, that you have to kind of look at not just the tool itself, but all the different systems and pieces and parts that kind of feed into the tool.
Thank you, Susan. Kathleen, have you seen changes in how nurse and patient assignments are managed since adopting OncoSmart?
Yeah, we've absolutely seen quite a few changes. All of our clinics now do nursing assignments. Sometimes they're done the day before, so we're able to adjust staffing because of the information we can put into OncoSmart, and we can pull over into the iAssign regarding like chair length times, patient acuities. We do acuities based on the complexity of the treatment, not nurse to patient ratios. We're able to pull in whether they are hazardous or non-hazardous. And we're able to build into the background. If we have pregnant nurses, we can mark those nurses that we don't want them to have hazardous drug patients. If we have an LPN in the infusion room or we are able to mark that they're only able to get certain patients. We now sometimes staff medical assistants in the treatment rooms because they're able to help access ports, coordinate chairs. We're able to pull a lot of data in real time. I can open up any one of our clinics and look and see what the nurse acuities are for that given day, what their total acuity points are as a clinic overall. I can see the skill mix of the ratios. I can fine tune it down to the point of knowing exactly how many patients a nurse had in a chair simultaneously, and we're able to either aggregate that or do it on an individual basis. It's really helped us plan. We use it for FTE requests. If we are trying to determine if we need additional staff, we've used the data to determine if we need to extend hours of the clinics. Do we need to bring patients in a little earlier, have staff stay later? So that's helped us build our shifts that staff work in order to stagger and get optimal coverage as we've flattened out that bell curve. So there's lots and lots of information that is in there, and yes, it's absolutely changed how we've done assignments. Even as Larry mentioned earlier, you can create an assignment for the day, but if you have a lot of cancellations or add-on, you're able to go in and force an adjustment of just the new patients, the ones that have not already been seated in a chair, which is really nice because it saves the managers or the charge nurses. That's who have access to iAssign, our managers and our charge nurses. That's what allows them to generate those assignments really quickly instead of spending tons of time doing it manually.
Thank you, Kathleen. You did speak to extended hours. How has patient capacity and particularly the need for extended hours changed since implementation?
So absolutely something that we look at. We are still able to, we struggle like most infusion centers and doctors' offices do with decoupling. And so we're able to see if we still have those gaps, or as Susan and Larry mentioned, if the schedulers are not using the optimizer and doing manual overrides. We can see that very quickly that our schedule is not, we call it not balanced. The schedule is not balanced. So we have a lot of conversations with leaders in the clinics about balanced schedules. But if we see the schedule is balanced, that they are running at that 85% capacity consistently, and things are still squeezed, or if they're running at capacity of over 100% on some days repeatedly, it helps us figure out, do we need to potentially extend hours? Do we need to think about adding more chairs if we have that ability to add more chairs and more staff? So it has given us that ability to use data rather than kind of anecdotal. Yeah, we think this is what's happening. It gives us that solid evidence to support our decisions.
Thank you, Kathleen. I had one more question for you regarding nurse satisfaction and patient to nurse ratios. Have you seen any change or improvement since adopting OncoSmart?
Having been a nurse for 43 years, I will tell you, nurse satisfaction is a thing you chase constantly. But I do think it is better in that they are with the use of the acuity tool and iAssign. I think it is better knowing that the workload is more even. Nurse A doesn't have, 4 patients that are all very less complex patients, while Nurse B has 4 patients that are very, very complicated. Again, we don't really use nurse to patient ratios at Tennessee Oncology, but we do know that a nurse can only handle a certain number of patients in chairs simultaneously. So that's become a secondary, even though it's not our formal, we use acuity. And, I can quickly look in iAssign, or if the nurses are expressing concern that they're not getting lunches, or they don't have time to chart, those kind of things. We can quickly go in there and we can validate that, yes, they may have had 8 patients for the day or 6 patients for the day, but they were all crunched together. And so then we go back and we look at, decoupling, and we look at was a scheduling optimizer being used. One of the things we talked about recently was that we have a provider that's always behind. So we were able to work with that particular provider, trying to determine why they're behind. Because if the nurses can get the patients in the chair and they feel like they are giving the patients the attention they deserve, then their satisfaction is good.
Thank you,
Priscilla,
Kathleen.
I'll just add to that, Kathleen's comments. I think that, one of the benefits that I have seen from a nurse satisfaction perspective is just, once again, we have the visibility into the data. And so when they are saying, to Kathleen's point, we're not getting lunches, or we're having to stay till 5, or, we have this one kind of a repeat offender, if you will, that's, they're always an hour behind and things like that. We can actually share data with them and work together with that leadership team and the staff members to help find solutions and, figure out where we need to go. So I think from my perspective and just hearing the feedback, that the nurses appreciate that, because they are being heard. And then there's also data and information that can be shared with them, because sometimes the picture may actually be a little different than maybe what the thought is, and we can at least be honest and transparent with them and show them what we are seeing, and they can be part of the solution. So I think that's also been a great benefit of this system, and being able to have access to this data.
Thank you, Susan. Moving on to some of our performance indicators, we have some questions for you, Larry. Smyrna offers the detailed business insights through the IntelliSite dashboard. Which of those metrics do you rely on most to guide daily or strategic decisions? You're on mute, Larry.
I am, yep. So many. So I hope my internet is more stable now. We've covered a lot through this. Susan talked about some of the business stuff earlier, which I think is really important. We've used data from OncoSmart to help us determine where we need to put nurse practitioners, because maybe the physician's schedule is overbooked often, and we have that data to be able to make those cases, to add chairs to the clinic, things like that. Kathleen talked about all different ways that we can look at new, nurses, stuff like that. I was going to use an anecdote to really put it, like, we had this issue that we noticed in the data where we saw delays on the lab side, right? And so at the very start of the day, we had several clinics that had this huge peak in wait times in the lab, and it was just really, really interesting. And so we did a little bit of an analysis, and then we took it to Susan's team, and we talked to each of the clinics individually, and they went and kind of dug into it. And what we found was, like, there was a couple of different things going on, but it was things that were very fixable. It was things like the MLT, the patients were coming in at 7:30, but the MLT wasn't coming in until 8, right? And so the patient had to wait until 8 o'clock to get their blood processed. And so just making that little switch of having MLT come in a little bit earlier completely fixed that. So there's a lot of data in there, and I know that you guys want to get to Q&A, so I don't want to belabor the point here, but there's so much data when it comes to lab, physician visit, MA, treatment room, injections, which are all the biggest things that we do. There's so much data in there that you can use to help try to paint a picture. And I think Kathleen said it earlier, we all anecdotally have done this for so many years where, I work in a treatment room, it's busy, we need to add more people here. But now, as business people, it's hard for us to swallow that pill nowadays. We need the data, and we have that data now, and it's helped us immensely. And I'll let Susan and Kathleen add to that, but it's been huge.
Yeah, I think the only thing I would add, Larry, is that, I think it's given, the operational team, so the team that I work with the closest, just some accountability as well. So when you can go in and you can dive into the details of the report, as Kathleen was saying, you can get very granular on a lot of these things. And so as a leadership team, you're having to look into, situations and challenges that occur. This data just provides you with a wealth of knowledge, and it does help make informed decisions based on what you're seeing. So I know that the regional directors that I work closely with over the medical oncology clinics, they look at the tool OncoSmart all the time, and they're typically sharing that information with their operations managers. They're collaborating with Kathleen on challenges. It's one of those things that I think they use on a routine basis for many different things. I'm sure we could spend a lot of time diving into all the different data elements and points, but there's just so much in there. I would kind of challenge to say that something that you're looking for is not in there with the experience that we've had, because every question that we've posed to Larry, he's been able to get us the data to give us what we need. So it's been extremely helpful and beneficial, and just information that we've just never had access to before.
Thank you, Susan. I know we do have a lot of questions in the chat box. I had two more questions to go through for our discussion, and then we can go ahead and transfer over to those. One is for Larry, if you can share any additional insights into platform enhancements. And then I think for all three of you, how has the post-implementation support been?
Yeah, so for platform enhancements, I mean, we're working on things like automatic scheduling, like RPA, robotic process automation, where the system can schedule automatically for you. And there's a couple of different use cases for that. We're testing something at Tennessee Oncology where we're going to have AI sort of talk to the patient and be able to use natural language processing to get the information from the patient, and then use some other APIs and stuff to do some translation. But ultimately, the end goal is we get this information to SMRTA, and it's able to either unschedule or schedule the appointment in OncoEMR, which is huge. And I think there's some other possibilities there too that Susan and I have discussed, that maybe even on the scheduling side that we might want to embrace something where the schedulers could just pick a time and it would automatically schedule for them, instead of just having the recommendations and seeing seeing what's available within the system itself. We're working on a nurse acuity algorithm. We're hoping that we can do automatic calculations. I think some places have acuity. A lot of times it's proprietary to those institutions, but we're trying to come up with a systemic way to calculate acuity on the back end. So maybe we can use that data for things. We're working on a nurse staffing algorithm that we just published at ASCO Quality, where we're able to predict the staffing that you would need in the treatment room based on a lot of different factors, like your chemo percentages, the amount of chemo, the amount of time the patient needs in the chair, things like that. We're working on that. Working on a couple other things, from a larger operational look, from like a staffing dashboard, or huddle dashboard that's real time for the leadership to be able to see. So we've got a lot of things that the SMRTA team has really been good about working with us on trying to grow and enhance the needs that we have.
Thank you, Larry. I think we'll go ahead and move on to our audience Q&A section. Just as a reminder to everyone attending the webinar, you can submit your questions in the Q&A box at the bottom of your screen. But moving on to one of our first questions we got from the audience, can you share how SMRTA's scheduling optimization tools have filled or supplemented critical gaps or addressed limitations encountered with the EMR scheduling functionality?
Yeah, so I'm happy to start, and then I'm sure Larry and Kathleen probably both have some insights from their perspective. So I think just overall, EMRs are, not really focused on scheduling from my experience, right? Scheduling is kind of a supplemental thing that happens in the EMR, and, not that it's, their fault that they have that, but they're investing in other pieces and parts. And so what the OncoSmart platform has provided for us is just really an opportunity to enhance kind of that core functionality. So, with what our EMR does, it predicts and plans out a patient's schedule. So we know when they're supposed to come in for labs and office visits, treatments, scans, so forth and so on. But once again, that is, one patient out of, could be hundreds of patients coming in on that same day. So what it's done is it's narrowed down and really provided very specific guidance to the schedulers on how do you fit this one patient into the overall puzzle piece of the day without them having to manually look at multiple schedules and, try to find out the best openings. There's guidance that it can give them automatically. So it saved us time from a patient perspective on scheduling and the checkout process. And then I think too, it's created more standardization and more opportunity for us as an organization to guide those schedules versus having it in the hands of multiple schedulers just trying to figure out how to put it together.
Thank you, Susan. Larry or Kathleen, did you have anything to add before we move on to another question?
I don't.
No, Susan covered it well. I think the one thing that's really important to remember is that there's still sort of a human element to this, right? So training, making sure that everyone understands why you're doing this is extremely important, because at least for now, when we're just making the recommendations, if the schedulers aren't picking those recommendations, you're still going to have the same problems that you had before. And so just want to make sure that people keep that in mind as they're thinking about this.
Thank you, Larry. Our next question, I believe, is in regard to coupled or decoupled appointments. The question is, do you use the chemo-ready treatment plans or labs, MD visits, and infusion on the same day?
So I'm happy to take that one. We have a mix. We are like, again, most infusion centers across the country, and that is, we have some visits that are decoupled, some visits that are not. Some of it is provider preference. Some of it is patient-specific requirements, lack of transportation, trying to fit treatments into work schedules or childcare needs, those type of things. So it's a mix. Some of our clinics are as low as maybe a 30% decoupled, where we have the physician's visit and the lab visits on a separate day. Some are maybe as high as 60%, but I don't believe we have anyone over 60 to 65% of decoupled. So again, we do a mix. It does work for both of those. But we do find that as far as balancing the nurses' assignments, it's better if we can decouple, because then you're not dependent on if the physician gets behind. But again, we are a private community practice. So if our doctors don't want to decouple, they don't decouple. and we work with that and with the system.
Yeah, and I will also add what Kathleen said. You have to take into consideration kind of, your organization and, your clinics. At Tennessee Oncology, we have some locations that are only open one day a week. So we're in some very rural areas. So we had to take that into consideration. That's one great thing from OncoSmart is it really works in any scenario, right? It works in the large kind of, our largest clinics that run, 250 patients through in a day, but it also works in our rural clinics where we have one day a week. Although we can't, maybe optimize the part of the decoupling, we can make sure that we have the right staffing and we're prepared and try to balance things out as much as possible. And that's where the OncoSmart tools really help.
Yeah. And Susan's exactly correct. I mean, we have some clinics that may do our what we call satellite clinics that may do 10 treatments a day. And we have other clinics that might do 120 treatments a day. And there is, while we phased in those smaller clinics last, as we were determining the benefit of the tool, we did make the decision to put it in place at all locations because we found that benefit.
Yeah, and I think what's really important on everything that Kathleen and Susan just said is that there may be pieces of the entire OncoSmart platform that maybe aren't as beneficial. So I'll use iAssign as an example. If you go to a one-day-a-week clinic and you have two nurses, maybe iAssign's not that helpful because it's two nurses, right? Like there's no assignment needs to happen. But what is really important is two major things. And Susan and I have been like just on like this has just been what all we've talked about for like the last several weeks, it seems like standardizing how you're looking at all of your clinics across the entire network, standardizing how things are being done, how the patients are being scheduled. That is huge. And then having the data that is same across all of the clinics as well, right? You don't want to have, the delayed data at your larger clinics, but not have the delayed data at your small clinics. So I just encourage you to talk to Ron, about your specific needs and your clinic sizes and your chair counts and things like that. And he'll work with you and make sure you get the support package that you need. He did with us. We have a little bit of a different support package at the smaller clinics than we do at the larger clinics, but we're
Right.
getting the core things that we need in the background, and that's what matters.
Thank you all. You did all just address another question that we had in the chat that was, is there a minimum size for a clinic that is required for OncoSmart to be beneficial? And it does sound like you did indicate that it is beneficial even for your smaller clinics. So thank you for clarifying that. Our next question is, how has SMRTA's scheduling optimization solutions influenced the patient experience when managing coupled versus decoupled appointment types? Specifically, can you share any observed impacts, positive or negative, on patient satisfaction, wait times, or care coordination when using the tool to support either approach?
It can be a two-edged sword, is sometimes how I think of it, because from our patients were very used to basically saying, I want to come at 10 o'clock, 10 o'clock, and we would schedule them. So as we went live with the SMRTA tool, we had to change our vocabulary, which was very difficult for some patients. And we switched instead to saying, well, we have appointment availability at X time or X time. So that was a shift for patients. And initially there was some negativity associated by that. But a lot of our discussions also surrounded by, well, if we see you at 1 instead of at 10, you're not going to wait because you may have come in at 10 o'clock, but all the chairs were full. And so you didn't end up getting treated until 1 o'clock anyway. So I think that's been more satisfying for the patients in that if we're able to optimize the schedule and stay on time, then they are being seen and treated quicker as far as the I-assign piece, or even getting in to see their MDs. If somebody's overbooked by 4 patients, you're going to wait in the lobby. And so that's helped with that piece of it.
Mm-hmm.
Yeah, Priscilla, I will just add to what Kathleen has said. I am out in the clinics and talk to the management teams and the team members a lot. And we actually opened up our largest facility a few months ago where we have imaging, medical oncology, our CAR T, our blood cancers. We have a central pharmacy there, and we just actually today are seeing one of our first patients in our drug development unit for research. But I've heard so many patient stories from the team there where just what Kathleen has said, when they've had this conversation with the patient, the patient is like, I always come in at 10 a.m. And they're like, oh, we understand that. But if you come in at 1, and you'll be here probably less than 30 minutes. If you come in at 10, you might be here for a few hours. And we actually have had patients that have said, okay, I'll give it a try and see how it goes. And then the end result at the end of that visit is like, oh, this was so great. I was in and out so quickly. So, when you talk to the patients and just try to give them that context, I think they appreciate it. But it definitely is a change from what we had done before, because we were just accommodating the patient without really knowing what that meant for them in that visit. So to me, that is the most significant impact on the patient experience, is we can actually help guide them on why 1 o'clock is better than 10 o'clock. And then they will actually see the difference when they come into the office for that visit.
Yeah.
Thank you both for that. That was great information. What key advice would you give for a successful adoption of OncoSmart? I do feel that we covered this a little bit in the discussion earlier, but is there anything else that you'd like to add?
Yeah, I mean, I think, transparency and communication, I'm of the school of over communication is the best communication, because you want to make sure everyone understands what the goals are while we're doing something, when we're doing it, make sure that they have the tools and the education. So I think, engaging your management team members so that they can be champions along with that physician champion that I mentioned earlier is really important. I will also say utilize the expertise of the SMERTA team during the implementation. Look at your data, make sure you understand what you have. Start from your physician templates and work your way through, because that time that you invest kind of pre-implementation is going to help set you up for a successful implementation. And yes, it does take some time in the beginning to get all of those things, but once you've got a few clinics going, then you really have a template that you can just kind of copy and paste from there, and fill in the details of each of those clinics specifically. So my advice, leverage the SMERTA team. There's some wonderful expertise on that team. Take into account their guidance, look into things in the beginning, so that can lead you to successful implementation. And then just really invest in your communication and your engagement of all your leaders, your physician leaders, your leaders within the clinic, and then also your team members so that they understand the goals.
Yeah, and I would just add on to what Susan has shared that, it's not going to be perfect to start, and you just continue to tweak and refine as it goes in place. But the other thing would be that you do have to do follow-up as well. We have found that as additional users, as we've changed managers, as we've added new staff, it's always good to circle back and make sure they understand all the capabilities of the program and the tool. Particularly, again, I'm much more heavily in iAssign, but sometimes people forget that iAssign can do things. So we have to circle back and we have to make sure that their templates haven't changed behind the scenes and they didn't tell someone. And so it does require maintenance for the adoption to be ongoingly successful.
Thank you all so much. Since we only have about 2 minutes left, I think this brings us to the end of our session today. But we want to say a huge thank you to Susan, Kathleen, and Larry from Tennessee Oncology for sharing your time and your insights with all of us today. And thank you to everyone who joined us. We hope you found today's discussion valuable. And please remember to complete the short survey at the end of the session, and also keep an eye into your inbox for the recording link.
Priscilla, can I say one thing also before we go? I think this is really important too. And I swear Rom didn't pay me to say this, but I deal with a lot of vendors, and many of you guys on the phone I'm not sure what mix we have on the phone. Smyrna has genuinely been, I'm not saying this because Rom's sitting here, but Smyrna has generally been the best vendor that we have worked with. They are accommodating any idea we come up with. They listen to, they help us work through it, generally say, yes, we can help you figure that out. And I can't say enough about that. So even, the solution to the side, just having a partner like that that's willing to work with us and listen to us, it's been huge. So I think everyone on the phone needs to understand that too.
No,
Yeah.
I
For
agree.
that, Larry.
Yeah, absolutely, Larry.
Yeah, couldn't have said it better, Larry.
Thank you all so much.
Yeah, thank you.
We very
Thank you, Larry.
much appreciate your feedback. And thank you everyone for joining us. If you have any follow-up questions, please submit them to Alberto at albertoanaya@smyrna.com, and that email address can be found on the screen now.
Thanks, everybody.
Thank you all.
Thank
Bye,
you.
everyone.
Thank you. Yep. Thank you.
Bye.